Okay, I'm Nitin Walyat, neonatologist, medical director of NICU, Ashner LSU. Today I'm going to talk about body composition in preterm infants. And this is my disclosure slide. So let's talk a little bit what we know about neonatal nutrition. My first slide is talking about a little bit about background. So what we know about body composition. We don't have enough studies. What we don't know how their body composition goes as babies are getting big because there are not enough studies. It's a relatively new field. We know body composition in adults, older children, but in neonates, especially preterms, this is again a new field. And how do we measure body composition is again very controversial and very limited options. So today we will discuss about what we know, what are the future implications, and what are the tools to measure the body composition. The second point I want to discuss about is fetal origin of adult disease. And we all are very familiar with Barker hypothesis. David Barker was an English physician and epidemiologist. So he did a lot of work on fetal origin hypothesis. So what it means is impaired fetal growth, or babies who are like IUGR, who are born small, there is some programming which happens while they are still in utero. And that is in fact a key determinant of adult diseases such as obesity, type 2 diabetes, cardiovascular disease, and I will also add polycystic ovarian disease. So it all starts in utero. And again, we will spend some time on fetal origin hypothesis. Then, we will talk about extrauterine growth. What we know is postnatal growth lag, or babies who don't grow well, this is associated with adverse neurological outcomes. What I also want to talk about is a little bit about catch-up growth. We want babies to grow, gain weight, but now we know that this might increase the incidence of cardiovascular disease in later life if it is not done properly. Again, as for neonatologists, we have to choose, we have to make sure that babies grow, gain adequate weight, because if they don't, then it is associated with poor neurodevelopmental outcomes. At the same time, aggressive nutritional supplement resulting in catch-up growth and relative visceral adiposity may result to metabolic and cardiovascular morbidities. So this is one paper talked about perinatal growth failure and how it leads to obesity, insulin resistance, and cardiovascular disease in adults. So one thing we need to understand is Thrifty fetal genotypes. Okay, so this is very important. So what does Thrifty phenotype means? This is fetal adaptation or fetal programming in an environment or a maternal environment which is limited in supply by the nutrients. So you have a fetal growth which is affected, baby's IUGR, or baby is somehow affected and is not getting enough nutrients. So at that point, there is a fetal adaptation or programming. One of the changes that takes place is DNA methylation. Okay, the study of this is called epigenetics. So fetal is already programmed to survive in that maternal environment which is limited in supply by the nutrients. So after the baby is born, now we start focusing on postnatal catch-up growth. Okay, so and we feed them and we take good care of the babies and they start gaining weight. But what that leads to is insulin resistance. And that's what causes obesity, adulthood diseases like we talked, hypertension, type 2 diabetes, and polycystic ovarian disease. So this is where it all starts. So I wanted to start here that, we are very aggressive with nutrition. We want these babies to gain weight, and we look at their weight. We have all those curves. But we have to think about this. So later down the road, we may be causing some more harm. The other big thing we talk about is extrauterine growth. So when babies are in utero, they are getting all the nutrients, they are getting the calcium, they are getting the phosphorus, and what happens when they go out? So what I will talk is mostly about preterm infants, low birth, extra low birth, or very low birth weight babies. So they come out, and I think almost all of us have seen that, when they are born, they may be appropriate for gestational age, but by the time they go home and you look at their centiles, it has gone down. So can we approximate the intrauterine growth? Is there a way we can match those growth curves? And should we even try? Okay. Dr. Pramanik said no. So postnatal malnutrition and growth retardation. So we have to see when these babies are born, 24, 25 weekers, and we have seen that they have so many issues: sepsis, PDA, bad RDS, bleed. So that's why it's it's difficult to start feeds. And if we start feeds, we do it slowly. And there are times when we have to stop feeds. They get conditions like necrotizing enterocolitis. So we are looking at all these morbidities which affect their growth. So preterm infants inevitably accumulate a significant nutrient deficit in first few weeks of life. That will not be replaced when current RDIs or recommended dietary intakes are fed. So this is a slide I put here. What I wanted to show here was, if you look, this is the energy calories per kilo, what they are getting. This is the protein, okay? So their intake is going up, okay? But here you look at this cumulative deficit. It is going down. So cumulative deficit is when the actual intake is what we are giving does not meet the recommended dietary intake, or you subtract actual dietary intake from recommended dietary intake. So this inevitably happens. So the solid, the black circles are for the babies more than 30 weeks, and this is for babies less than 30 weeks. So you see these less than 30 weeks. So it is always going down. So there is always a cumulative deficit. Very difficult to achieve a curve like this. And you can see the changes in the z-score. So it is pretty significant. Okay? So this is postnatal malnutrition. So extrauterine growth restriction remains a serious problem in our premature newborn babies. So the other focus of my presentation is body composition. Okay, and in the end, I will discuss my research project, my fellowship research project, and I will present my study briefly. So this is the body composition, and we know we have some standard values. We have curves for adults, for children, but in preterm, again, the studies are very few and limited. So this is one table, I got from Lippincott Williams. It is actually for babies after birth. 0.5 is 15 days, then 3 months, 6 months, 9 months. And how we look at the body composition is fat-free mass, which is, you can say, lean body mass. Fat mass, it's an absolute measure, and percentage of fat. So when we compare, usually they compare the percentage of fat mass. And this is one of the values, at 15 days in term babies, 14 plus 0.2 in girls, 11.4 in boys. And we do have some body composition references for preterm infants. In last year, it was published and it is AAP recommended or approved. This is for babies born 30 weeks and above. And they measured the body composition within 72 hours of birth. So these babies were relatively stable, and you have fat-free mass or lean body mass. These are the values. You can look at the centiles. For the fat mass here, and then percentage fat. So there are some reference values available. Not much, but there are few. Okay. How do you measure a body composition in a baby? There are various techniques. The two big ones are the Dexa scan, dual energy X-ray absorptiometry, and the new techniques that's being used nowadays is air displacement plethysmography using PPOD. I will talk about PPOD, and this is what I used in my fellowship, and this is how we did the body composition of premature babies. So PPOD uses a simple theory. It calculates the body density based, and we know the formula, body mass divided by the volume. And what it gives you is two-compartment model. Two-compartment means you get fat mass and fat-free mass. There is also four-compartment model, which is, this is how you get results from Dexa scans. Four-compartment model is you break the fat-free mass into lean body mass, but it also includes total body water and bone mineral content. And PPOD it provides an accurate, technically very easy, and the big advantage of PPOD is it does not use radiation. So this is the PPOD. This is a slide from a fellowship project, and I would bring these premature babies, put them in PPOD. It takes less than a minute. You don't have to sedate them, okay, and it does not involve any radiation. So I'm sure people have worked with Dexa scans. Dexa scan, first of all, you have to sedate the baby. If the baby is crying and you cannot do it. Secondly, it does involve radiation too. Okay, so this is PPOD. An adult version is called BodyPOD. Okay. I think the cost is around 90 grand, but this is the most common use method of measuring babies in preterm babies, body composition. So again, this PPOD provides reliable, accurate, and immediate assessment of body composition. If you bring a 30-week gestation baby or 32, you know you have to get the baby back in the unit pretty soon. Otherwise, it's going to get cold, and then baby starts crying, and you can't get anything done. So this takes about a minute. Okay. So highly suitable for measuring the body composition in preterm infants. So there are other methods. Okay, isotope dilution. ADP is air displacement plethysmography or PPOD. And the other commonly used method is Dexa scan. Nowadays, people are not using it that much, as I said, because it involves radiation, takes too much time, and you have to sedate the babies. Okay? Some research studies, they are also looking at MRI, but again, it is very expensive, and not many studies have been there using MRI. So this is one study looked at the body composition in very preterm infants. What are the role of characteristics and nutrition? Can they achieve growth similar to term infants? When they are term or corrected gestational age close to term, is their body composition similar to term infants? So this is, I highlighted the role of nutrition here. High protein intake could achieve a growth velocity similar to intrauterine weight gain. Okay. Caution with lipids. We give lipids, we need lipids for essential fatty acid deficiency, but again, too much lipid is not good because it increases the fat mass and subsequently increases the risk of cardiovascular morbidities. Okay. So body composition changes in preterm, again, how do you compare them with term infants? So in this study, it was markedly lower fat-free mass or lean body mass and higher adiposity was observed in preterm infants at term-corrected gestational age. But in this study, the differences became less as they approached 3 to 4 months. So there was significantly higher difference at discharge, but it became less significant 3 to 4 months later. So the other aspect, what I was talking earlier was about extrauterine growth restriction or postnatal malnutrition. And we all know that it does affect their neurological outcomes. So this is one study which looked at the neurodevelopment and metabolic outcomes at 4 years of age. So in this study, the early fat-free mass gains was associated with faster speed of processing, whereas fat mass gains was associated with higher blood pressures. This is another good study I found, and I'll talk about this study. This study was done in France, and what they looked at was preterm infants and their fat-free mass and its association with neurological outcome. So there were 172 infants less than 33 weeks who were enrolled, and for some reason 15 babies, they could not do the body composition, but 157, they did the body composition using PPOD, and then they looked at their neurological outcome. So this was using ASQ, Ages and Stages Questionnaire. So this was parent completed questionnaire, and it looked at 5 areas of development. Their fine motor skills, gross motor skills, communication, personal social skills, and problem-solving skills. So what they concluded was the maximum scores were 300. So this less than 186 was suboptimal, and this was pretty good. So what the conclusion was, the fat mass at discharge, was associated with suboptimal ASQ scores. And the Z-score of fat-free mass or lean body mass, again, was associated with neurological outcomes. So this is, again, very important. On one hand, we know suboptimal nutrition can affect their neurological outcome, and on the other hand, too much, or if we do, feed them too much, it can be harmful in terms of cardiovascular morbidities. Okay, so I'll talk briefly about my study. This is the study I did in my fellowship project, and the hypothesis was current nutritional regimens produce preterm infants with lower free fat mass and higher percentage fat mass than term infants. And again, why we did this study was there is very limited data available in the literature, and whatever is available is controversial. And very few published studies on body composition in infants. So the objectives were compare the body composition of preterm infants born at 24 weeks to 29 weeks of gestation, and then compare it with term infants at 37 to 42 weeks of gestation. And in preterm group, we also followed the body composition trend. And we also looked at the effect of nutrition. So how does nutrition play on the body composition in these preterm infants? Okay. So the primary outcome was comparing the preterms versus term infants. Secondary outcomes was following the changes in the preterm group and looking at the effect of nutrition. We also did some basic Skinfold measurements, triceps and subscapular fold. It was done using PPOD, air displacement plethysmography. And again, it's a 2-compartment model, and you get percentage fat mass, and fat-free mass. Okay? And fat-free mass is lean body mass. So this was the nutritional assessment, proteins, calories, and total fluids. So we included babies who were born at 24 to 29 weeks of gestation. And when we did the PPOD measurements, they were relatively stable, either in room air or on very minimal oxygen. They were on full enteral feeds. And the control group was recruited from the newborn nursery between 37 to 42 weeks of gestation. SGA babies or babies who received postnatal steroids or chromosomal genital anomalies, multiple gestations, they were all excluded. Okay. So first we recruited the babies born between 24 and 29 weeks of gestation. First body measurement was done, again, when they were able to maintain their body temperature and full feeds. And once we had a preterm infant who was recruited, we recruited a term infant matched for race and gender from newborn nursery. So the repeat body composition was done on the preterm before discharge. There was at least 1 week gap between the first and second measurements. And again, we had a daily nutritional data was collected from the charts. Appropriate statistics were done. So we had 68 babies in this study, 38 preterm and 30 term infants. And we had a study done earlier in the institution. Based on that, we calculated the sample size. 36 preterm and 26 term infants fulfilled the criteria. 2 preterms were outside 35 to 42, so they were excluded. And in the term babies, we excluded 4 because they were infant of diabetic mom. And 21 of the 38 recruited preterms, they had a second measurement. So I followed the trend of these 21 babies while they were still in NICU. The results, this was expected. Birth weight was significantly low in the preterm group. The other thing which we saw in preterm infants, they were mostly non-white. So here's the results, and as you can see, the preterm infants, the percentage fat mass was significantly higher compared to the term group, 17.3 versus 13.2. The fat-free mass or lean body mass was higher in the term group compared to this preterm, and the total body mass was also higher in the term group. So again, the percentage fat mass was significantly higher in preterm compared to the term group, 17.5 versus 13.3. And the results were still significant after adjusting for gestational age using analysis of covariance. So 21 infants or preterms, they had a second body composition measurement. And this is their trend. So you can see this is the first measurement and this is the second measurement. And you can see the percentage fat mass is significantly higher at the time of second body composition measurement. So they are gaining more fat. And you can see the body mass is increasing, but we also saw the lean body mass was also higher at the time of second measurement. Okay. But what I would like to conclude was percentage of fat mass was significantly higher at second body composition than the first measurement. Looking at their nutrition, the significant difference was proteins. They got less protein as recommended. So what we found in regarding to nutrition was the protein intake was significantly associated with fat mass and lean body mass, but not the total calories. So this is very important. Quantity does not matter. Quality is what matters. Okay. So once we have a preterm infants, we need to make sure that they get adequate proteins. Okay. We give them special care formula, preterm formulas. And if I ask you why we give these formulas, the number one reason is, of course, calcium and phosphorus. The second reason is proteins. Calories is probably the third. Okay? So they are on preterm formulas because it has more proteins and more calcium and phosphorus. There was not much difference in the tricep measurement, tricep fold measurement, but subscapular was higher in preterm groups. So they had more subcutaneous fat. So the conclusions from our study was former preterm infants at near term have higher percentage of fat mass and lower fat-free or lean body mass compared to term healthy newborns. Percentage of fat mass accumulates rapidly in preterm infants towards the end of hospital stay at the expense of gains in lean body mass. So they gain more fat mass as compared to lean body mass. And preterm infants do not receive the recommended amount of energy or protein. And I showed the slide earlier where they all have the cumulative deficits. And this is also what we saw in our study, that their protein intake was lower than the recommended dietary intake. So, premature infants, too fat or too lean? So something that we have to think about. Too fat, we give them calories, we look at their weight, but they may be gaining too much fat, and they may be at risk for all the cardiovascular morbidities. Or too lean. How to make them lean? Give them more proteins. Catch-up growth is important, but it has to be regulated. So again, there are not enough studies. The data what we have is very limited. So accumulation of fat in preterm infants, good news or bad news? So, we know the pros and cons. We want them to gain weight, but we also have to look what kind of weight they are gaining. Okay? We don't have enough tools. The tool that I used was PPOD. So maybe in near future, we will be looking at the body composition before we send them home. Or when they go home, we can follow them as an outpatient. Okay? So what we are coming to is the body composition. What kind of weight they are gaining is very important. On the other hand, we don't want to give them suboptimal nutrition because it affects their neurological outcome. Okay? So again, it has to be regulated, and a close follow-up is very essential. And the study that I did, we looked at the body composition in babies who were born 24 weeks and above. Mostly studies, the data that you have is less than 28, or some studies less than 27 weeks. So, but we were able to look at the body composition in these extremely low birth weight babies. Again, we need more studies, and what's right, what's wrong, we don't know. So in future, or what we can do from these studies or this data is develop some nutritional strategies, protocols to achieve catch-up growth, which is very important, but try to have a normal body composition. Normal body composition, what is normal? We do have some reference values, but what we should try to achieve is lean body mass at the expense of fat mass. Because even you go and see all the older kids, adult population, the single most pathology for all these diseases is insulin resistance. And if they have too much fat, that leads to insulin resistance.
Yes, very nice, but I think it's important for the residents. You did mention protein quality. There were a large number of studies that were done in the 1970s that showed as you tried to increase protein, if you weren't extremely careful with the protein quality, you tended to develop a metabolic acidosis in the infants that was also quite detrimental. And if you try to push protein, you will one of the things that we see is damage to kidneys eventually. So you have to be very careful with protein quality. The other thing that I thought was very nice that you mentioned was the methylation that occurs in utero. Perhaps Dr. Prouty would like to comment on the generations later, if you have been undernourished in utero, your grandchildren may have problems with insulin resistance because of this, and I don't know if people really appreciate that.
And this is something called epigenetics, and Dr. Prouty can probably talk about it. So, and again, this is a separate studies, and it is again very important. We need to understand this because it does affect future generations and the same person later on in the life.
Yeah, the epigenetic role in this, I think, is huge. And the Thrifty genotype that you were talking about comes about because at least in early gestation, or most particularly in early gestation, if there is famine-like conditions, the fetus will shut down certain genes, the expression of certain genes, by epigenetic means. So it's not changing the base sequence of the DNA, but simply regulating which genes are going to be expressed. And so this results in the Thrifty genotype, the Thrifty phenotype, where the fetus is being told, be prepared for famine conditions when you are born. And this epigenetic marker, these markers can continue through the generations. They can be in the formation of subsequent gametes. These markers can be passed on. So what you can be looking at is people who are raised under conditions of confined nutrition, having babies who are prone to, programmed to have the Thrifty genotype, and be able to process their foods much more efficiently, and they will put on weight. So that it's transgenerational. But what interests me also is the comparison with what you're seeing here with the Dutch hunger winter, which in September of 1944, the Germans occupying Holland, at least the eastern part of Holland, imposed a kind of blockade of food reaching eastern Holland as punishment for people in that region who were resisting the occupation. And this went on from September of 44 until May of 45, when Holland was liberated. So babies in the early part who were being gestated and feeling the effects of that blockade, they were epigenetically marked for the Thrifty phenotype. Those who were simply at the later stages of gestation, when the hunger winter started, they were born with less birth weight, but they recovered better. They had catch-up growth. But I'm very interested in the fact that these premature babies have this high lipid concentration. That adds a little insight into what was going on with the babies who were subject to the earlier in gestational age. And it is certainly true that babies born resulting from the hunger winter were born and went on later on to have obesity problems and cardiovascular problems and some neurological problems. And this is well documented by the Dutch because they have a national health program, and they it's a very interesting period to read up on.
It's very interesting summary. In premature babies, they also have deficiency of all the metabolic enzymes which are needed to utilize lipids. So is it the lipid accumulation because there is inefficiency in the metabolism of diet which consists of lipids, or
when we give them TPN, the amount of, we start intralipid slowly, and then we increase it to say 3 grams per kilo, and then we can monitor the triglyceride level, see if they are tolerating that lipid load or not. Some babies don't, so you have to cut down their the lipids. So maybe they have some enzyme issues and they cannot, like lipoprotein lipase, so they cannot metabolize that excessive lipid. And the problem in short term is because hyperlipidemia can affect their gas exchange. It can cause lung issues too. In the long run, it might lead to adiposity. But we need a little amount of lipids, 0.5 gram to 1 gram per kilo, to prevent essential fatty acid deficiency in babies who are not on enteral feeds. So that is the minimum amount. But then you increase the lipids because 1 gram of lipid will give you 9 calories. So that is for the calories. But again, every baby is different. Some babies can tolerate the excess lipid load, some babies don't.
These premature babies, they have deficiency of lecithin cholesterol acetyltransferase, very important for lipid metabolism. Secondly, the triglyceride levels. Did you see any differences in the triglyceride levels between these two groups?
No.
Okay. So it's circulating lipid levels are similar. And epigenetic modifications are important. Is it there are epigenetic changes in the premature babies, or it's the lipid accumulation that leads to epigenetic changes?
I don't know, but I don't think it has anything to do with lipids. It is just they are exposed to that environment and they program.
That's okay.
Yeah, that is. I don't think it has anything to do with the lipids. It happens in utero.
Well, we have done studies recently that increase in the oxidative stress because of lipids or GSH deficiency can lead to epigenetic changes. And
That you're talking after birth?
Yeah, after birth, if we have excess lipids, it will lead to more lipid stress, oxidative stress, and that can lead to epigenetic modification, and which can lead to vicious cycle of.
We routinely measure triglycerides.
Yeah, I'm not aware of these changes after birth. What I know and I read is it's in utero that is what I was talking about. But I don't know if it happens after birth.
Yeah, you can have epigenetic changes after stages in infancy to childhood. Yes, it can happen then too.
So I don't know the role of lipids that we give can cause epigenetics.
It's mainly lung issues.
Yeah, the lung is acute tummy.
Triglycerides and you've got
exactly.
accumulation in the
Because it does affect the AA gradient and diffusion of gas.
capillary alveolar.
Right.
So that's where it's,
AA.
in the old days when we used to die, you see lipid depletion stage.
Exactly, yeah.
Number one. Number two, we worry about the free fatty acids. If you're giving too much lipid, that will, as you know, 6 to 1 molar ratio. Free fatty acids to albumin. If you go above that, 5 or 6, the chances of your baby having
This is like huge changes we see, and we try not to give them too much because it can cause all these acute changes. But I'm not aware of epigenetics related to excessive lipid or maybe.
It is a great overview. I often share with our residents and students, go back to Nelson's textbook. He's my father of pediatrics. He's shown in his old life, has the good fortune of running it in my younger days, that body composition, depending on what gestation you're talking about, 24-weeker, 22-weeker, it's 80 to 90% is water. So therefore, coming back to the methodology, to my knowledge, we used to use dual X-ray photometer to look at bone mineral and fractures, and Dr. Ku also trained with Reggie, so we used to do all that. But then what stood the test of time? These are all research tools, including the pod, and also nobody actually doing it. So one has to be careful about methodology. You were talking
about the timing when you do it.
Yeah, timing, how you do it, and coefficient of variation. Any test will have around 100 times variation. Are you doing it in the same place, same time? What got your data is that babies we don't. We should have predominant fat. That's how they are measuring maintaining the temperature. So whether that, because you're measuring the endoscapular area, correct?
No, that was a Skinfold thickness. Some old, they look at the subcutaneous fat. So, but body composition has nothing to do with subcutaneous
fat.
Right.
Well, the point I'm making is very hard to do body composition in a subject who is 80% water.
No, but that is upon the time. If you do all babies when the fetus is born, it is about 80% water, especially in these extremely premature. But as the time goes on, you see all the babies lose weight, and that is physiological. Why is it physiological? Because they get rid of the extracellular fluid. But in our study, the measurement was done when they were on full feeds, about 34 to 35 weeks gestational age. So at that time, you don't have that extracellular water. But in first few days, you have extracellular fluid. That's why they have more body water. And then they get rid of that extracellular fluid, and you see the physiological weight drop. But this body composition what we did was later on in life, when they were on full feeds.
Right, but clinically most people just look at weight length, had to look at the growth of the child. One has to be very cautious. What are you measuring? What is your intake? What is output? The last comment I'll make is, when all we're taking care of these tiny kids are fetuses, right? So in utero, that fetus is getting its nutritional source and therefore body composition via transplacental transfer. So as you said, no good studies. One has to look at the maternal nutrition, whether she's obese, what kind of obesity she's got, whether she's got pregnancy-induced hypertension. There are few maternal studies, but they're not all that great. And familial and placenta, all these have to be put together because that's a unit, maternal fetal unit.
Yeah, and these studies have looked at, especially the effect of maternal smoking and maternal education on this fetal malnutrition. And the two big things that come out is maternal smoking and maternal education. You're right.
My question on the same token that the water content of the body, when you do this test, would it have effect? Like suppose if a body with fat will float better on water, so would this plethysmography, that's why preterm babies have difference in...
No, but again, it depends on the timing you do.
Yeah, but I'm just saying like a 24-weeker, if you take this water content or fat content, would it be a reflection of body water in terms of...
It might be because, we are using the body density.
Yeah, this displacement of whatever is, I'm just like of the same token that because they have...
It won't be accurate in the first few days because of more total body water. Because it will affect the body density.
That's what, okay.
And our concern always is epidemiologically again, the SGA kids, which were ruled out but one, because that's the group that is triggered, or if you genetically programmed, if you will, to develop metabolic syndrome in subsequent generations. Very, very well shown by the Australians, by the Indians, because as you said, pastor famine theory, and now they put in epigenetics.
Thank you. Excellent.